smaller bites and breathe deeply while chewing. Clear the airways of mucus at least 1 hour before eating. Encourage the patient to rest and use bronchodilators before meals. Try drinking liquids at the end of the meal. Drinking before or during the meal may increase feelings of fullness or bloating. Eat while sitting up to make it easier for lung expansion. Use fast breathing. Bloating or gas. People may experience more bloating or gas when they have to eat. Avoid overeating. To avoid overeating, we have to eat smaller meals. Avoid foods that cause bloating or gas, vary depending on the person, such as broccoli, cabbage, beans, cauliflower, radishes, onion, turnips, and fries, rich or heavily spiced foods. And the COPD patient must eat slowly, chew food well, and avoid caffeine. Avoid drinking while eating to avoid swallowing gas. Limit intake of carbonated beverages. Keep mucus, water, taste sensations. Drink 6 to 8 glasses of non-caffeinated fluid to keep mucus clean and easy to cough up. Milk and dairy products do not produce more mucus but can coat mucus already present. Try drinking half a cup of 100% orange juice after having dairy products to help keep mucus. In COPD patients, they have dental problems. It can cause mouth pain and make it more difficult to eat. Alterations should be made in food, textures, and consistency to aid in chewing and swallowing. For example, try sweet cream instead of pork sauce or cooked vegetables instead of raw vegetables. In COPD patients, fatigue is very much common. So people may feel too tired to take, eat, or lack the energy needed for eating. This causes some people to shorten the length of time spent eating. Rest before meals, eat smaller, more frequent meals, eat your largest meal when you have the most energy. Make easy to prepare meals and make extra to freeze if possible for times of increased fatigue. Use oven or microwave cooking rather than stove top. Some people may find it tiring to stand at the stove top. Ask family to help with meal preparation. Make appropriate referrals to home care and meals on which is available. Reliance on oxygen of COPD patients. Food intake may be limited when reliant on oxygen. Use oxygen while eating if needed or use oxygen while finished eating. Most of the COPD patients have constipation. People may experience more constipation when they have COPD. Make sure client has adequate fluid intake and it should be 6 to 8 cups per day. Increase dietary fibers such as whole grains, beans, vegetables, and fruits, cereals, whole grains, pasta, and rice. Recommended to aim for 25 to 35 grams of fiber per day. Exercise as tolerated. Nutrition for COPD and common complication and solution. Nutrient recommendations. Energy. When a person has COPD, more energy is needed in order to breathe. The muscles used in breathing may require 10 times more calories than those of a person without COPD. Consuming more energy than your body requires is more recommended as it puts additional stress on the lung and heart function. When a person consumes excess energy, the body produces more carbon dioxide, which causes increased respiration rate. In past research, it was thought that an excess intake of carbohydrates led to increased carbon dioxide production. Current literature proposes that excess consumption of energy is more significant in the production of increased carbon dioxide than intake of carbohydrates. A patient who is hazardous may require a high energy and protein diet. Person who is overnight may require an energy restricted diet to help them lose weight to help improve respiration. The person who has had significant weight loss, such as a weight loss of 5% of their body weight in the previous month or 10% of their body weight in the previous 6 months, can be provided with high energy and protein diet. 0% weight then because the usual body weight minus actual body weight into 100 usual body weight. It's a calculation. If the client is overweight, then what to do? Reduce portion sizes, continue to consume 2 to 3 servings of meat and alternatives per day, limit high fat and high sugar foods such as hot dogs, french fries, longer foods, pop, chips, candy, etc. Eat high fiber foods to get you feel foods such as fruits, vegetables, whole wheat bread, brown rice, oatmeal, cereals, etc. Physical activity as advised by your doctor. Now, protein. Intake needs to be adequate to prevent muscle breakdown and maintain lung strength. Eating well with Canada's food guide recommends 2 servings of meat and alternatives per day for women and 3 servings for men. The person who is well nourished will require additional protein. The person needing to lose weight may benefit from limiting their portion sizes of meat, chicken, and fish. Excess protein should be avoided in those with chronic diseases as it can decrease kidney function. Then how much fluid a COPD patient should take? Adequate fluid is needed to hydrate the body and help mucus in and easy to cough up. It is recommended to consume approximately 6 to 8 cups of non-caffeinated fluid per day. This can include water, milk, 100% juice, tea, soup, etc. Some people with COPD who also have congestive heart failure might need to limit their fluid intake. Fluid requirement should be discussed with client's doctor. Sodium. Eating too much sodium can cause your body to retain fluid, making breathing more difficult. The recommended intake is 2300 mg or less of sodium per day. That is, it may 1 teaspoonful of salt. This includes sodium added during cooking at the table as what is added to food products. This to decrease sodium intake, limit processed foods such as bacon, ready-made, stolen, etc. Remove salt shaker from table. Use herbs or non-salt spices like pepper, onion powder, garlic powder, or whatever. Avoid adding salt to food while eating. Read food labels and avoid foods with more than 300 mg of sodium per serving. Salt substitute may not be for everyone. The client should check with their doctor before using salt substitutes such as half salt. Osteoporosis. People with COPD are at an increased risk of osteoporosis if they have used corticosteroids long term. Calcium and vitamin D supplementation is recommended as bone loss is significant after the initiation of statin steroid treatment. It is recommended that the client take 1200 mg of calcium and 1000 IU of vitamin D. The patient should be encouraged to use calcium and vitamin D with food and exercise if possible. Going to refractive dietitian. Respiratory physician sometimes may consult with the dietitian for their patients. A client who has had significant weight loss, such as a weight loss of 5% of their body weight in the previous month or 10% of their body weight in the previous month, or obese client who requires nutritional education to achieve weight loss. A client who has several weight gain, health problems in addition to COPD, This is all happened.
Reliable opinions regarding the topics that are presented in this session.
Excellent presentation on the shoulder, especially nutritional development support with COPD patient. By SN Abdul Rajak, President of Respiratory Medicine. Excellent presentation, especially generally habit, dietary habitation, কিছু বেসিক হ্যাবিটও আমাদের সিস্টেমে ইনক্লুড করেছে যাতে করে সিওপিডি পেশেন্টগুলোর ক্ষেত্রে দেখিয়েছে। অ্যাকচুয়ালি আমরা যখন সিওপিডি পেশেন্ট ট্রিটমেন্ট করি মেডিকেল ম্যানেজমেন্টের দিকে আমরা বেশি আমার মনে গুরুত্ব দিই, কিন্তু ডায়েটরি হ্যাবিট, নিউট্রিশনাল হ্যাবিটের উপরে আমরা হয়তো ততখানি গুরুত্ব দিই। এই ব্যাপারগুলি সামাজিক সমস্যা, এটা সোশ্যাল প্রবলেম, লাখে লাভ চান্স অনেক কম, এর জন্য আমার মনে হয় অনেক লাগিয়ে তো এই সোশ্যাল প্রবলেম এবং কিছু আমি হ্যান্ড ওভার করছি কিছু ইনফরমেশন যে কিন্তু আমাদের রেসপিরেটরি ল্যাবে হচ্ছে এখন, এবং যার টিচার হিসেবে দায়িত্ব পালন করছেন ডাক্তার লুৎফর রহমান নিজে। তো বাইরে থেকে যারা আসছেন তাদের কাছে আমি এই ইনফরমেশনগুলো দিয়ে দিচ্ছি যে স্নো রেসপিরেটরি ল্যাবে আমাদের টোটাল ম্যানেজমেন্ট হচ্ছে। যদি আপনারা এই ধরনের কোনো পেশেন্ট পান বা পেশেন্ট যদি অন্য জায়গায় রেফার না করে আমাদের এনআইএস রেসপিরেটরি ল্যাবে রেফার করে লুৎফর কাছে আমরা সরকারিভাবে সুস্থ চিকিৎসা করতে পারবো। ধন্যবাদ আপনাদের সবাইকে। পরবর্তী মাধ্যমে অনুরোধ করছি এটা আব্দুর রহমানের কাছে।
Thank you. First of all, gratitude to the organizer for giving me the opportunity. Two papers are represented in this session. Virtually, these papers are somehow different. First paper is presented by Dr. Lutfur Rahman. Stop the snow. We know the snow actually is the prime presentation of obstructive sleep apnea. But some nuance information we have here that snoring causes injury of the aortic and subsequently developing the atherosclerosis, and it causes defective mechanism of the patient. As a whole, this presentation and information is very excellent. My thanks to Dr. Next paper is presented by Professor Abdul Rajak. Really, it is an excellent and different paper because whenever we test or deal with the management of the patient of COPD, virtually we are looking for the drug treatment of the patient. We should carry some additional management for the COPD patient, and it is during the physical exercise, during the intubation of the patient, quitting of the smoking, as well as looking about the dietary factor of the patient, and giving the information about the diet. Already Dr. Rajak giving us the information that should be about the respiratory quotient, how many oxygen atom oxygen is absorbed by production of the carbon dioxide, and it is usually the carbohydrate. Dr. Rajak mentioned the carbohydrate is that within the maximum amount of by absorption of the oxygen. So we should care about the tidal pattern whenever giving the advice of the national toxicity. Finally, my heartiest thanks to both speakers for the excellent presentation. With the few words, I hand over the microphone to the teacher, chairperson, Professor. Good afternoon. I think everybody is now very much my two students, SM Lutfur Rahman and SM Abdul Razak, that very much appreciated to me. They are very nice. Stop the story. It is very proud. I think this problem is very much prominent in the approach than in our country, especially in foreign countries. Thousands of cows remove their husband only for food, unless it is treated. But thank that in our country, the cows and the women are very good. They are very much devoted to their husbands, and that's why they don't depart their husbands. I pay my thanks and tribute to our cows and our women in this country. However, the paper is very nice, and he has elaborated describe everything, especially about obstetric apnea syndrome, which causes both cardiac and respiratory or social problems, and he has given the immunity. And also, Abdul Razak has mentioned the nutritional support is CPD is very common in our country, and I think nutritional support can play a great role to mitigate the sufferings of this patient. With these few words, thanks everybody. Good afternoon.
Now we are about the end of the session, the time for the program of this session. May I request the chairpersons and the co-chair of this session to make up the program of this session to speakers. First speaker, Dr. A. Chandra. Next speaker, Dr. S. Abdul. Thank you. Now the presentation of the token of appreciation to the chairperson and the podium. May I request to present the token of appreciation, and I request Mr. Said Islam, Associate Professor of Psychology, to present the token of appreciation to the podium. This is the end of the session 5. Now the time for the episode of punctuality. Session punctuality left to draw.
যদি প্রতিটি সেশনে থাকতে হয় এবং এবারে আপনি আমাদের এই সেশনের সম্মানিত সভাপতি স্যারকে রিকোয়েস্ট করবো স্যার এখান থেকে বাস্তবায়নের নাম তুলে দেবেন দেখে স্যার 66 Asina 66 Making last card 208 Abdul Hassan 208 73 Rukia Sultana 9 Naki Rukia Sultana 73 9 Rahim bhai those are people nalle dora Abu Rahman Baro sir আমি তো পিছনে দিয়েছি সরি রাহিম ভাই এই সভাপতি ব্যক্তি আবু রাহিম ভাই আমরা সভাপতি হিরণ স্যারের কাছ থেকে এই পুরস্কারটি নেওয়ার জন্য অনুরোধ করছি রাহিম ভাইকে রাহিম ভাই এখানে রেজিস্ট্রেশন এর দেন সেক্রেটারি এরপরে গতকালকে খোঁজার জন্য আমি সাইডের থেকে রিকোয়েস্ট করব সাইডের পরের ভাগবত নাই তারপর নাই পরের 14 আব্দুল রাজ্জাক আসেন আল্লাহ না বিজন হয়ে গেছে এই সেশনে আমাদের অ্যাসোসিয়েশনের মধ্যে ভাগ করে গেছে আরেকটু নাম নিয়ে বলে আমি বলতাম আরেকটা Thank you, sir.
So, learned audience, now the last session, session 6. The chairperson of the session was Dr. Nija Mohammed Khan, Dr. Krishna Chandra Gangoli, and Dr. Mohammed Hassan. And the other moved here of the may I request the chairperson of the here to come to the diagram. Please. Don't worry, after this session, after the event, we are waiting for that. So, for this session, I request the rapporteur of the Islam to start the session.
Respected teachers, dear audience, this is the last segment of today's presentation. Though it is last, it's not the least, because all of the three topics, say, the central area of construction, management of pulmonary hypertension, and update of management of COPD, all are vital of all the physicians. COPD is a disease of high morbidity and mortality with high physical cost. We first hear from update of management of COPD.
Chairpersons, dear rapporteurs, learned audience, very good afternoon. Welcome all of you to my session. My topic is update management of COPD. I divide my topic into four parts: the background knowledge, available medications, what is needed, and evidence-based approach to combination therapy in COPD. First, I would like to say the definition of COPD. It's a preventable and treatable disease characterized by persistent airflow limitation that is equally progressive and associated with an enhanced chronic inflammatory response in the airways and the lungs to noxious particles or gases. And global burden of this disease is top 10 causes of the death, the years of life cost, and the premature death, among which the COPD in respect of the death, it is ranking 5. And in Bangladesh scenario, the national wide survey carried on 2006 to 2007 increased the total number of estimated COPD patients were 59,47,200. Across 40 years, the patients are 21.24% and total population 4.24%. The risk factors of COPD, especially smoking, occupational dust and chemicals, environmental work smoke, indoor and outdoor air pollution, the genes, infection, the socioeconomic status, and aging population. The mechanism of underlying airflow limitation in COPD, the small airways disease and the parenchymal restriction, follows two root causes the airflow limitation. And the air trapping in COPD, if you see the left hand side the normal and in right hand side the COPD patient, it is a small airway inspiration, that is the alveolar attachment is alright. And on the other hand of the right side, there is a thickened airway and loss of alveolar attachment and loss of elasticity. For diagnosis of the COPD, we go through the symptoms and exposure to the risk factors like dyspnea, chronic cough, chronic food production, tobacco smoking, occupation, indoor and outdoor pollution, and through spirometry, diagnose the COPD cases. And if we take a look over the COPD and asthma cases, we see that in COPD, the oxygen midlife, people slowly progressively long smoking history, and the main key treatment is bronchodilator. On the other hand, of the asthma, the onset early life, the symptoms vary from day to day. Symptoms post at night and early morning, and family history of asthma present. And their main treatment, key treatment is the inhaled steroid. This is the basic difference between COPD and asthma. Effect of the exacerbations in COPD. The patients with frequent exacerbations, the greater airway inflammation, the poor quality of life, the faster decline in the lung function, more hospital admissions, and ultimately the higher mortality rate. And whom to treat and how? The recommendation of the treatment no longer based on only the biometric staging, but also it will depend on the existing symptoms, frequency of exacerbation, and degree of airflow limitations as evidenced by spirometry. And how to approach? It is smoking, cessation, and prevention of environmental control. Then we see the medications and healthy lifestyle, vaccinations, pulmonary rehabilitation, oxygen therapy, etc. In medications, we see there is a LABA, that is long-acting beta-2 agonist, LABA, very long-acting beta-2 agonist, short-acting beta-2 agonist, short-acting anti-muscarinic agent, long-acting anti-muscarinic agent, and phosphodiesterase 4 inhibitor, and inhaled corticosteroid along with the long-acting LABA. And go to 15 initial pharmacology, 4 groups, group A, B, C, and D. And aim of the treatment to reduce the existing symptoms, to decrease the risk of are the mainstay of treatment due to their proven efficacy. And available medications, that is the SABA, salbutamol, SAMA, the short-acting antimuscarinic agent diplatopium, LABA, salmeterol, formoterol, the longer half-life 8 to 12 hours, the LAMA, long-acting antimuscarinic agent, tiotropium, glycopyridinium, actinium bromide, and these very long-acting beta-2 agonists, indacaterol, and silanetrol, and olodaterol. What is new? Short-acting bronchodilator was the cornerstone of treatment for the past 2 decades. 15 years ago, twice daily LABA became available for maintenance therapy, and for the last 10 years, once daily LABA tiotropium is available. In 2009, the LABA indacaterol was launched, and glycopyridinium was launched in 2012. Indacaterol and glycopyridinium from 2014. Combining the bronchodilators with COPD, current guidelines recommended adding a second bronchodilator to therapy in moderate COPD in order to optimize the symptom benefit for the patient. Combining the bronchodilators of different pharmacology classes may improve efficacy and decrease the risk of side effects compared to the increasing the dose of a single bronchodilator. The evidence-based approach to the combination therapy in COPD, indacaterol and glycopyridinium, is a combination of indacaterol 110 microgram and glycopyridinium 50 microgram for single daily use. Here you can see the beta-2 agonist and muscarinic antagonist in COPD, the sites of action. The anticholinergic agents are more effective in the proximal airway, which is brown color, and beta-2 adrenergic receptors, which are effective in the distal airway. The antimuscarinic bronchodilators, which relax the airway smooth muscle by blocking the cholinergic flow. And beta-2 agonist bronchodilators relax airway smooth muscle by activating the beta-2 receptors. They are the additive effects of indacaterol and glycopyridinium. This is the pie diagram, bar diagram, where we see combination provides a greater improvement in lung function than LAMA alone. It is also and rationally of a combined medication, despite the availability of effective bronchodilators in some patients with moderate to severe COPD, symptoms can be poorly controlled by bronchodilator monotherapy. In these cases, the addition of a second bronchodilator from a different pharmacological class could be beneficial. Introduced in 2009 as the first once daily, very long-acting beta-2 agonist for maintenance bronchodilator treatment of sterile COPD. It acts by relaxing the airway smooth muscle by binding to airway beta-2 agonist receptors. Glycopyridinium bromide, long-acting muscarinic antagonist, and acts as a competitive antagonist by selectively binding to the muscarinic receptors in the bronchial smooth musculature, thus inhibiting acetylcholine-mediated bronchoconstriction. And evidence from a recent review of 2015 that the authors of the article review the evidence from the published randomized trial. Because of their bioavailability, inhaled bronchodilators may have systemic effects of which particularly relieving in cardiovascular system, that is, for example, the tachycardia, increased blood pressure, the prolonged QT interval, hyperglycemia, hypokalemia, and muscle tremor. Many patients with COPD are elderly and often have several comorbidities. Thus, it is particularly important to evaluate the safety of the maintenance bronchodilator treatment, especially when multiple bronchodilators are administered simultaneously. And in the study by the Beckman and the colleagues, 1.3% of the patients in indacaterol of glycopyridinium treatment group has acute intubation leading to the discontinuation compared with 4.3% in the placebo group. Cardiovascular safety was also confirmed by Andy Mel and colleagues who compared indicatorol and glycopyrronium at different doses. Now conclusion. The currently recommended treatment for established COPD is based on the bronchodilators, which include the long-acting LABA, V-LABA and LAMA. Drugs with a long duration are preferable to various favored patients. Adherence is rational that associating a long-acting bronchodilator to another with a different mechanism of action allows the achievement of better symptomatic relief in moderate to severe. In particular, of the control trials show the good efficacy and safety of the new association of the V-LABA indicatorol and the LAMA glycopyrronium as assessed by both symptom reduction and improvement of quality of life. And thank you all.
Thanks, Dr. Niranjan Shah, for your nice presentation on the latest management protocol of COPD. Dear audience, we know pulmonary hypertension is a great new method. Recently, we have got updated categorization and management, evidence-based management on pulmonary hypertension. Now, the speaker is Nigar Sultana Ahmed. Our topic is pulmonary hypertension and its management.
Thank you, sir. Thank you very much. Honorable chairpersons, respected teachers, distinguished guests, and learned audience, Assalamu alaikum and a very good evening. We are running very short of time. This is the last session of today, and we all are very tired, and so do I. So, with the kind permission of the chair, I would like to go on in a very nutshell about the pulmonary hypertension and its management. So, you all know about the pulmonary circulation. It's a low resistance, high compliance vascular bed. This is the only organ to receive entire cardiac output. Changes in cardiac output as well as pleural and alveolar pressure affect pulmonary blood flow. The reactions are somewhat different than in comparison with the systemic circulation, and this is normally in a state of mild vasodilatation. This slide shows the classes of recommendation, and this shows the level of evidence. All these are needed for the treatment purpose, as you know. Now, definition of the pulmonary hypertension. Simply speaking, pulmonary hypertension is increase in the pressure in pulmonary circulation. But hemodynamically, it is defined as mean pulmonary arterial pressure more than 25 mm or mercury at rest and more than equal to 30 mm mercury after exercise. And the left heart pathology should be excluded by pulmonary arterial wedge pressure less than or equal to 15 mm of mercury. And the pulmonary muscular resistance would be more than 3 Wood units. And all these should be measured by right heart catheterization. But yes, we can also guess from echocardiography, also from fixed equation. This is the severity of the pulmonary hypertension. As you all know about the previous classification, that is the primary and secondary pulmonary hypertension. In primary, there is no etiology, but in secondary, the pulmonary hypertension develops due to other diseases. in 2008, there is revised, updated clinical classification of the pulmonary hypertension, which was taken in the fourth World Symposium of Pulmonary Hypertension held at Ghana Point. Here, there are 5 groups of pulmonary hypertension. The group 1, pulmonary hypertension, that is the pulmonary arterial hypertension. Here are some diseases: idiopathic pulmonary hypertension, primary pulmonary heritable pulmonary hypertension, and some disease like connective tissue disease, HIV infection, congenital heart disease, chronic hemolytic anemia, persistent pulmonary hypertension of the newborn, pulmonary vein occlusive disease, and the pulmonary capillary hemangiomas. These all causes share the similar pathophysiology, and the drug response is similar. So these all are in group 1 pulmonary hypertension. Group 2 pulmonary hypertension is due to left heart failure that might be due to systolic diastolic dysfunction or valvular disease. Group 3 pulmonary hypertension due to lung disease or hypoxia. Group 4 is chronic thromboembolic pulmonary hypertension. Group 5 pulmonary hypertension is due to multifactorial mechanisms. These are some drugs which are responsible for inducing pulmonary arterial hypertension. In this picture, you can see actually where the lesion is. In group 1, pulmonary arterial hypertension, the lesion is in the pulmonary artery. In group 2, the lesion is in the left heart, and in group 3, group 3 and group 4, the lesion is in the pulmonary capillaries. If a person is genetically susceptible and there is presence of risk factors like collagen vascular disease or others, there is vascular injury, that is, there will be increase in the vasoconstrictors and decrease in the vasodilators, and also there is impairment of the voltage-gated potassium channels that leads to disease progression. There is smooth muscle hypertrophy, adventitial and intimal proliferation, cerebral thrombosis, and plexiform lesion. Here you can see the pathogenesis. This is the pulmonary artery diameter, and see what happened to the diameter at the end of the pulmonary hypertension. The plexiform lesion is irreversible pulmonary arterial hypertension. This slide shows the direct toxin effects of cigarette smoking. And group 4 pulmonary hypertension, that is the chronic thromboembolic pulmonary hypertension, non-resolution of the acute embolic masses, which later on undergo mechanical obstruction and develops pulmonary hypertension. Group 5, as I mentioned earlier, due to multifactorial. And what history should we take from pulmonary hypertension? History of smoking, recreational drug use, systemic hypertension, sinuses, meningitis, musculoskeletal pain, and so on. The symptoms of pulmonary hypertension. The symptoms are really vague. The restlessness, chest pain, and palpitation. And we encounter a lot of patients in United States and other than United States, but we have to have a high index of suspicion to diagnose pulmonary arterial hypertension, because it is a relentlessly progressive disease and we have to diagnose it to intervene early. So physical findings, because the ultimate result is right heart failure, so we will get the signs of right heart failure. This slide shows the diagnostic workup of pulmonary arterial hypertension. From history and examination, after we have to do the chest X-ray and the ECG. And if there is the index of suspicion of pulmonary hypertension, enlargement, left heart disease, valvular heart diseases, and congenital heart diseases. After that, we can do the VQ scan to exclude chronic thromboembolic pulmonary hypertension, because this is a potentially remediable disease organized embolism, then pulmonary hypertension will be improved. We can do the pulmonary function test. We have to see the ventilatory function at gas exchange, overnight oximetry and polysomnography to exclude sleep disorder, HIV, ANA, liver function test, and other connective tissue disease, serologies to exclude HIV infection, scleroderma, SLE, rheumatoid arthritis, and pulmonary hypertension. Then we can do the functional test by 6-minute walk test and cardiopulmonary exercise test to establish the baseline and prognosis. And in the last but not the least, the right heart catheterization to confirm the pulmonary hypertension, hemodynamic profile, and vasodilator response. This is the chest X-ray pulmonary hypertension, echocardiography, CT scan. Here you can see the diameter of the aorta here, and this is the pulmonary artery. We have to thromboembolic pulmonary hypertension, as I mentioned earlier, ventilation perfusion scan, pulmonary angiogram, and this is the organized thrombi that was removed. This slide shows the 4 prognostic factors. Now the question comes, who do we treat for pulmonary arterial hypertension? The treatment is absolutely based on functional status. How do we treat them? There are some general measures, there are some medication, and in the end, surgical therapy. This slide shows as there is imbalance within the vasoconstrictor and vasodilator, as I mentioned earlier. So our main target of therapy is here. And because there is nitric oxide deficiency, so we can give the phosphatidylserine 5 inhibitor like sildenafil, tadalafil, and vardenafil. And we can also give guanylate cyclase stimulant. As there is prostacyclin deficiency, so we can give the prostacyclin analog like iloprost, treprostinil, and so on. All these are available in oral form, IV form, subcutaneous form, and even in inhalation form. As there is overexpression of the endothelin, so we can give the endothelin receptor antagonist like bosentan, ambrisentan, and sitaxantan. This slide shows the treatment. Irrespective of group of pulmonary arterial hypertension, we should take some general measures in all pulmonary hypertensive patients, like avoiding pregnancy, immunization with influenza and pneumococcal vaccination, supervised rehabilitation, psychosocial support, and avoid excessive physical activity. And we can also give some drugs like diuretics and oxygen therapy, oral anticoagulants, especially active pulmonary arterial hypertension, and digoxin. Then we can do the expert referral to do the acute vasoreactivity test. So if the vasoreactivity test is positive, then we can give the calcium channel blocker in the WHO functional class 1 to 3. And if there is sustained response, then we can continue it. But if there is no sustained response and the acute vasoreactivity test is negative, then the treatment would be on the basis of level of evidence and recommendation. And after doing so, if there is inadequate clinical response, then we can give the combination therapy of endothelin receptor antagonist, phosphatidylserine inhibitor, and prostanoid. If it is also inadequate, then we can go for surgery. So we can do atrial septicectomy and in the last lung transplantation. This slide shows the follow-up response to therapy. And in the end, I would like to say correct diagnosis must be established. Imperative dilator therapy is not recommended. Treatment options are frequently available if not seen at any stage. And thank you all, thank you Chairperson and all for patient hearing.
Thanks, Nivedana, for your giving presentation. Dear audience, we are at the end of our presentation, almost at the end. We know the therapeutic and preventive approach to central airway obstruction is the very important aspect of interventional pulmonology. Now, Dr. Jackie Hussain Sarkar, Assistant Professor of Respiratory Medicine, will give his speech on it. Respected Chairperson, reporter, learned audience, Assalamu alaikum. My topic is management of central airway obstruction. I will try to highlight the newer tools we are using in our country to manage central airway obstruction through bronchoscopy. As we know, central airways are trachea, mainstream bronchi, lower bronchi. So obstruction of any of these sides we call central airway obstruction. What are the types? These are abdominal, sphenic, or mixed. Now the symptoms. Symptoms are dyspnea, cough, wheezing, hemoptysis, atelectasis, and symptoms of post-obstructive pneumonia. What are the causes? Causes are malignant, non-malignant, and congenital. Malignant causes are primary lung tumors, primary airway tumors, meniscus tumors, digestive tumors. Commonest cause is malignant tumor. Non-malignant are acquired systemic diseases, miscellaneous. On the congenital causes are tracheomalacia, bronchomalacia, vascularity, membranous wave relapsing polychondritis. How to assess the patient? So clinical assessment. The presentation depends on the severity and location of the lesion. Presentation may be asymptomatic or life-threatening asphyxia. So what investigations we should do? We should go for pulmonary function test, imaging, and bronchoscopy. From pulmonary function test, we will not get that much information. Still, from blue or blue, we can get whether the obstruction is variable extrathoracic, variable intrathoracic, or fixed obstruction. And as you know, the presentation depends on severity and location of the lesion. And as I showed before, presentation can range from asymptomatic to life-threatening. And and for chest imaging, from chest X-ray, we we usually don't get that much information. But still, sometimes we get colors, teachers to colors, and the distorted airway color. And from CT scan, we get same thing in better resolution. But one important thing is that if we can do virtual bronchoscopy, we can see the extent of the lesion and the airway beyond the lesion. And through bronchoscopy, we can do flexible bronchoscopy, rigid bronchoscopy, and EBUS. EBUS, additional information whether the lesion is within the lumen only or infiltrating the wall or there is anything outside the airway. So how to manage? For immediate relief, we can do mechanical debridement, laser solidization, electrophysiology, argoplasma coagulation, cryoregeneration, balloon dilation. But when the lesion is smaller enough and the airway is still wetted, urgency is not needed, then we can think about therapy, photodynamic therapy. At present, we are doing mechanical debulking, electrophysiology, argoplasma coagulation, cryotherapy, and airway state. You know, mechanical debulking is done by rigid bronchoscope. It is very easy. Whenever there is a lesion, this scope is the equivalent of the rigid bronchoscope is used as chisel. And if we proceed the bronchoscope through the lesion, then the mask will cut off. But only precaution we should take that the axis of the bronchoscope should be in the same axis of the airway. Otherwise, airway will be injured. And it is of low cost and immediate results we can get. Another thing what we do is electrophysiology. This is a popular option for malignant central area obstruction. What accessories are used in electrophysiology? These are snares, coagulation scope, cutting knife, hot biopsy forceps. And contraindications are high flow oxygen, permanent pacemaker, defibrillation. You know, this is the gentleman who came to us with this airway obstruction of right principal bronchi. And through bronchoscopy, we saw that the right main bronchus is completely obstructed. Then we planned for electrophysiology. We did successfully, and we got a passage. So this is the result of electrophysiology. Another is this is tracheal stenosis, and this is the result of prolonged intubation. This is a case which can be relieved by electrophysiology, but ideally it should be done by laser followed by balloon dilation. Now about argoplasma coagulation, it is a non-contrast form of electrosurgical technique. It is low cost, excellent efficacy, patient control, bleeding. Not suitable for bulky endobronchial tumor because it can penetrate only around 2 millimeters. There is risk of endobronchial fire and alarming one is gas embolism. This is a case because this patient actually presented to us with a tracheal growth with high bond. We successfully placed a state 2 years back, and the patient was lost. And after 2 years, he appeared to us with stridor and severe respiratory disease. And hardly there is an opening in the airway. Then we planned for APC, argon plasma coagulation. We did the argon plasma coagulation. Then we did clean-up bronchoscopy. And after clean-up bronchoscopy, you can see the stent and the patent airway. Now this patient is waiting to go abroad. Now about exposing biological tissue to cycles of freezing and thawing causes cellular injury and death. Fibrous tissue and cartilages are resistant to cryodestruction, while there is less risk, it is usually resistant. Delayed necrosis occur over 5 to 10 days, so any arterial procedure you have to avoid cryotherapy. Clean up bronchoscopy is needed. And cryotherapy is suitable for destruction of exophytic tumors, soft mucosal and inflammatory growth. Usually in 90% cases, also suitable for highly vascular lesions. Can be used for removal of foreign bodies and obstructing blood clots. The complications are bleeding, bronchospasm, arrhythmia. Another interesting thing of cryotherapy is that is cryorecanalization. Newer instruments we have got, using this cryotherapy, you can prevent weak and larger lesions, and there is less risk of complication. And airway stents, as we know, have a critical role in maintaining airway patency, extending airway compression, remediating dyspnea, successful grinding and extubation in ventilator dependent patients. As I showed you before, complete operation of the right main bronchus, we did electrobotany, then we decided to place stent and to place the stent. So you see the airway is now patent. There is symptomatic bleeding. You see the distal part of airway through the stent in the right main bronchus. So in conclusion, I must say a single modality of bronchoscopic therapy may not be sufficient for all. A comprehensive treatment plan is needed. A dedicated airway team should work together for better outcomes. As there is obstruction in airway, there is difficulty in treatment as well. We should overcome someday, inshallah. Thank you. Thank you for listening. Thank you, Dr. Zakir Shorkar, for your informative presentation. If the audience has no question, I will be single question to Dr. Nigar Sultana, pulmonary hypertension. Dr. Nigar Sultana, I have a single question to you. I did not find the answer from your presentation, so your presentation was a very detailed one. Say, a patient with COPD or interstitial lung disease has developed pulmonary hypertension. Will you prescribe him targeted therapy of pulmonary hypertension like that of embryosandral or sildenafil? Yes or no? No, we will not.
And then after that, there are some evidence of a level of aggression after optimally treating the primary body with targeted therapy.
Yes, thank you. Actually, the information is that we will prescribe the targeted therapy only to the idiopathic pulmonary hypertension or to the pulmonary hypertension with connective tissue disease. Other in respiratory pulmonary hypertension or cardiac pulmonary hypertension, we will not prescribe those drugs. Thank you. Now is the time for chairperson's comment. First, Dr. Abu Khan, Associate Professor of Respiratory Medicine.
First of all, I want to give thanks Dr. Zakir Shorkar for his new and nice presentation about management of central airway obstruction. Secondly, I want to give thanks Dr. Nigar Sultana for her nice presentation about management of pulmonary hypertension. Last of all, I want to give thanks Dr. Viraj Shah for his nice presentation about complete management of COPD. Though COPD is not a curable disease, but it can be prevented.
we can prevent COPD by small decision or Thank you, everybody. And was my to Dr. Kessinger. Thank you, Mr. Chairman. Chairperson. The three papers presented in this session all are very brilliant, and the presentations are also very brilliant. I cannot resist my temptation to say something regarding the topics that are presented. COPD is a preventable disease and is the fourth leading cause of death and proceeding toward third. So many things are to be done to prevent COPD as well as to find out the unmet needs in the management of COPD. Dr. Nihantan Shaha has elaborately mentioned the management of COPD. It's a very good presentation. LABA and LAMA, well, these are now being used in our country, especially the LABA, interferon and LAMA glycopyrronium. But the thing is that yet the efficacy of LABA with ICS, I mean inhaled corticosteroid, seem to be more than LABA and LAMA and lower. So these things are to be cleared in near future. I think many molecules, novel molecules are coming, and we think very soon we will be clearing out. Before that, still we have to continue along with LABA as well as ICS along with LAMA. And also treating COPD patients, we must consider, because they are elderly people, we must consider the comorbid conditions associated with them. Many of them also have hypertension. One thing, we must not only smoking is the risk factor of heart disease, but COPD itself, aside from smoking, COPD itself is a risk factor of ischemic heart disease. And earlier you start treating a patient of COPD, the better is the prognosis. So we all should keep this in mind. Once again, I thank Dr. Nihantan Shaha. Pulmonary hypertension, I think this is less discussed topic among the pulmonologists even, and yet it is unsaid problem. Because the pulmonary card, I think assistant pulmonologist to treat a patient of pulmonary hypertension. And previously, when we were a student, we used to learn primary and secondary pulmonary hypertension. But from 2008, the Dana-Point classification has clearly emphasized the need to classify pulmonary hypertension group 1 and 1 prime. These are really idiopathic group of pulmonary arterial hypertension which we want to emphasize. And group 2 pulmonary hypertension is absolutely secondary to left heart failure. And group 3 is secondary to COPD or other lung diseases causing hypoxia. As our reporter raised the question whether somebody will treat a patient of pulmonary because of this is the answer is pulmonary hypertension. You have to treat the cause. It is not the idiopathic group or the drugs and toxins or the connective disorder which are causing the pulmonary hypertension, which are to be treated with targeted molecules like bosentan. But if you can treat them with vasoreactivity test, if it is vasoreactive positive, then you can use calcium channel blocker. So here catheterization, and we need the help of a cardiologist. But before that, we can assume whether the patient has got really pulmonary hypertension or not, because there is an equation. If you multiply the echocardiographically assessed pulmonary artery systolic pressure into 0.61 and add +2, then it becomes equal to the right heart catheterization pulmonary arterial hypertension. Suppose somebody has echocardiographically a pulmonary artery systolic pressure 40, that will be almost equal to 25 by right heart catheterization. So I am not going into further detail because this is really a very tough topic and requires more and more discussion. Once again, I would like to thank Dr. Nida Sultan Ahmed. She has nicely presented a difficult topic. And Dr. Zakir Hussain Sarkar. Dr. Zakir Hussain Sarkar is always one step advanced in our pulmonology department, I think. And nicely, he has presented the central area of obstruction and many newer techniques. He has mentioned mechanical, electrophoretic, argon plasma coagulation, laser, cryotherapy. Well, all these newer techniques and some is being practiced in our institute, some are not. And rightly, he has team is to expertise in this field. So I hope in near future our doctors will be trained either home or abroad, and we will be able to adopt these techniques in our country, and that will be giving pleasure to our patients. With all this, I once again like to thank Dr. Zakir Hussain Sarkar and thank to the executives of State of we thank them.
Now, the comment, very valuable comment from our beloved professor, Professor Mirza Muhammad Hiram sir.
Thank you. Basically, Dr. Abraham actually covered some key scientific papers. All three papers presented very nicely and consensus also excellent. But I will just evaluate the total scientific component. The papers presented, all the papers are not as complete. In some of the papers, they constructed, this is not up to mark, because just a book picture and they presented the slide in black and white. Now, total the scenario is digitalized. They should prepare their slide in a more beautiful way. It should be acceptable to the audience. I am not satisfied with all these papers, and I am more dissatisfied with the presentation of the students. Those who presented in their papers, contents are very good, but they just prepared in line way. I hope that in the future they will take more care in this presentation. This is the last session, but I am very happy with all the three speakers. They made their slides in a beautiful way, and this is very exciting. Of course, some of the other speakers they also presented in a nice way, but some of the papers quality was very low. I should request that in future they should concentrate on their papers. It should be more. It should be palatable to our normal participants. They should enjoy the things. So, however, we have actually enjoyed the number of the papers. There are more present others. So, it's very encouraging for us. But I declare them to be my caution preparing the papers in the future. So, in these few words, I'd like to conclude the today's scientific seminar here. You will enjoy the executive other section after this ending of our session. We quickly just finish our exam and then Rafael with these few words, I conclude this session here. Thank you very much.
Learned audience, we are at the end of the scientific session. And now, time for presentation of the token of application. It is the chairpersons and their body.